Good evening, everyone. My name is Simran Chaudhary, and I warmly welcome you all on behalf of Voice of Healthcare. And we are delighted to bring you to the fourth edition of National Virtual Forum on Hemophilia Care, proudly organized by Voice of Healthcare and supported by Roche Pharma. This year's forum is Early Detection to Timely Diagnosis, Bridging the Awareness Gap, which aims to spark critical conversation about the often overlooked yet vital topic of early hemophilia diagnosis. Timely detection not only saves life but also significantly improves the quality of life for patients and families affected by this rare bleeding disorder. So, starting with a round of discussion on understanding the current challenge in early detection, but I would also like to firstly introduce our speakers. I would like to start with Dr. N. Vijayakumar, Medical Officer in charge at HTC Aluva and Nodal Officer for NHM Asadhara project. Welcome to our show, sir. Dr. Bipin Kulkarni, Scientist E and Deputy Director at ICMR National Institute of Immunohaematology. Welcome, Dr. Bipin.
Thank you.
Thank you so much, sir. Dr. Neeraj Siddharthan, Clinical Professor and Head of the Department of Clinical Hematology at Amrita Hospital. Welcome, Dr. Neeraj. Thank you so much for joining. And together, we will help decode the current gaps in awareness screening and discuss the actionable solution to ensure early and equitable access to care. So, I would like to begin the dialogue with Dr. Vijayakumar. So, from your experience, what are the most early signs of hemophilia that are often missed in primary healthcare setting? So, I cannot hear you.
Sir, I think you are muted.
Dr. Narayana, I cannot hear you. You're muted now, so you can unmute. So, can you hear us? I think Dr. Narayana is facing some technical issues. Our team will get back on this. So I would like to ask my next question, Dr. Bipin Kulkarni. So, from a laboratory and diagnostic perspective, what systematic gaps do you observe from the delay that confirmation of hemophilia diagnosis is suspected case? So you're on mute.
Yeah, am I audible now?
Yes, I am
So,
audible.
yeah, so for say if you have to talk from the Indian point of view, so we have approximately 1,40,000 expected cases of hemophilia in the country. But if you see the number of laboratories available to diagnose or to reach to these cases, they are very, very few and far spread out. So the first limitation is the number of coagulation laboratories that are available for these patients and the specialized investigations which are or the testing which is done in the labs that are available, right? So there are very few labs. Now, if you have to talk of the HTCs in the country, there are approximately 250 to 300, probably more HTCs, where the factor treatment is available across the country. But if you see the number of diagnostic setups in the STCs, there are only about 13 to 15 that have the diagnostic setup for the factor 8 and other levels. Now, if you have to see the specialized testing, even when we talk of hemophilia, we also have to talk about von Willebrand antigen, because without that, hemophilia A diagnosis is incomplete. So only about 5 labs, 5 to 6 labs, is doing von Willebrand testing. Factor assays is also not done in many of the places. Now, if you see the district places, many of the labs do only the PT, so not even APDT is done. So these are the, like, if you have to talk from the lab point of view, these are some of the challenges or the deficiencies. Secondly, there is a need to have a better awareness, both amongst the medical caregiving fraternity as well as the public. So, like for example, if you have to take up, in most cases, the mild bleeding manifestations are missed. So it's important to take proper history. It's important to take details about the subtle bleeding disorders that can be there, which may mimic other conditions. So all these can be, there should be paid attention to in the by the medical fraternity. Otherwise, they can lead to delayed referral or no referral. So they go undiagnosed. Also, taking detailed family history, bleeding history, particularly when it comes to genetic disorders like hemophilia. So it is very important because we need to distinguish between hemophilia A and von Willebrand, as I said earlier. Then, when I said lack of laboratories, that also implies that there is lack of skilled manpower, skilled lab technicians to do these coagulation assays and to diagnose these patients correctly. And of course, when there is a so much deficit in the primary diagnosis, talking about genetic diagnosis is a far cry, because that only a couple of places are there where we can do the complete genetic diagnosis of hemophilia. So these, I think, are some of the major places where there are gaps which needs to be addressed very well.
Thank you so much, Dr. Kulkarni, for answering that question and creating that awareness amongst our audience and listeners. As it is very important, like we said, our initiative, our session aims to bridge the awareness gap which is not there. So thank you so much for creating that awareness. Moving on to my next question, Dr. Neeraj. So, in your clinical practice experience, what misconceptions among general practitioners contribute to delayed referrals for hemophilia diagnosis? So you're on mute, I believe, because I cannot hear you. No, sir, I cannot hear you. So I think, yeah.
Hello,
So now you muted yourself. Yes.
can you hear me? Yeah, sorry. Yeah. So thank you for the question. Actually, from a clinician's perspective, if I have to say, I think hemophilia, like Dr. Bipin mentioned, is a genetic disorder. Mostly, we see, hemophilia as an X-linked disorder affecting mostly male babies, male members of the family. So, and there is a pattern of inheritance. So, two-thirds of hemophilia, and one-third have born without family history. So, if you look into those two-third with family history, obviously the there is a there are gaps when as clinicians we take history, where we've seen that history of family disorders being overlooked in many cases. This is a very common mistake we do as clinicians, because we tend to focus on the patient only sometimes. So it's very important to add you know a question or two about the family members, and try and see if there's family history. And so if we ask for a family history, I think and we could get an insight into two-thirds of the hemophiliacs. Second thing is, many babies, when they are born with hemophilia, we don't, I mean, of course, we don't have a test at birth to check for hemophilia. Mostly our national programs do not have that. But the babies start bleeding probably when they start crawling, and or when they have some injuries. So uh, they bleed into many tissues and joints, skins, oral bleeds, and all can happen. But sometimes the bleed is not seen in hemophilia. So if you bleed into joint, the joint becomes quite stiff, and the baby is crying and not able to move a limb. And many a time, we as clinicians may think of something else because we are not seeing the blood, because bleed is into the joint. So that is another common, uh, error that we make as a clinician, that um, uh, we don't see blood, so we think it's something else. The third thing, of course, is uh, when during birth, sometimes we have seen, uh, during normal delivery, assisted deliveries are there, where we use vacuum or forceps for delivery in many cases, and the child has trauma to the head, and then you see bleeding in, hematoma in the head, and then at that time, it may be attributed to the forceps being used, but again, you know that may be a child with a bleeding disorder who is manifesting for the first time. Another aspect which I've seen is vaccination, because the children usually get vaccinated and then they develop a, because they're not diagnosed before that, and so they get intramuscular injections, and then sometimes that results in a trauma and an abscess formation. So it is challenging, and one of the cases that we have diagnosed was when the child had an intracranial bleed and was operated. And even for the surgery, the pre-op investigation sometimes is only a prothrombin time, like Dr. Bipin was mentioning. The tests are not everywhere. Even the test to diagnose in APTT is the test which is screens for hemophilia and von Willebrand disease, but APTT sometimes is not available even in medical colleges in the country. So even you tend to diagnose very late, as after the child develops a major bleed. So, and then of course, this can happen even in tertiary care centers. So there are like many cases, like Dr. Bipin was mentioning, we have about 140,000 cases probably, but we have not diagnosed all of them. We have not diagnosed all of them because one of the reasons is the access to care and the availability of the laboratory test at the primary referral center. The PT and APTT is not being available even at the primary referral centers or in some of the tertiary care centers also. So I think a few of the things that I've noticed during my practice is what I shared now. Thank you.
Hello.
Thank you so much, Dr.
Hello.
Neeraj, for answering that question. As we are moving to our next question to
Hello.
Dr. Vijayakumar. So,
Okay.
from your
Am I
yes,
audible?
yes, sir, you're audible. You're audible, sir.
Hello. Am I audible? Okay. Fine. 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 Okay.
So, sir, from your experience, what are the most
Because
common?
Dr. Neeraj is almost yes. Yes, please.
So, from your experience, what are the most common early
Most
signs of
common.
hemophilia that are often missed in primary healthcare settings? So I think we still cannot hear you.
I think if Dr. Vijayakumar sir keeps his camera off, the audio will be much clear. Probably his network is not very
Am
strong.
I audible? Am I audible?
Yes, sir,
Hello.
you're audible.
Okay.
Dr.
Okay. Then, as Neeraj mentioned, not even 20% of hemophiliacs in India are diagnosed. That is, there are several reasons for that, but the most important one is the lack of awareness among the public as well as among the healthcare providers, doctors, nurses, laboratory technicians, etc. That is why diagnosis is usually missed. The missed early signs, as you said, as prolonged bleeding during circumcision. In our place, circumcision is done immediately after birth or shortly thereafter. Then that is taken for granted. Then, as Dr. Neeraj mentioned, following vaccination, it is taken as infection, then toothbrushing, etc. Even large bruises are ignored, especially in children with dark skin. And painful swollen joints are attributed to injury and treated locally. There are instances where joints are aspirated also. Hemophilic joints are aspirated also. Then even bleeding into muscles might be mistaken for trauma and infection and treated like that. And a family history is seldom elicited because the hemophilia is not kept as a differential diagnosis. So that is these are the reasons. And as Dr. Neeraj mentioned, the facility to diagnose is very few. It has come up off late in the last decade. The facility has improved quite a lot, but still the facility is, especially in the north, is very few and far between. That these are the reasons why these are the why the early symptoms go undetected, and the people continue to suffer.
Thank you so much, Dr. Vijayakumar, for answering that question. And now we'll move on to our next segment, and I'll ask my question to Dr. Bipin. So, how can advances in molecular diagnostics and point of care technologies revolutionize early hemophilia detection in resource limited settings?
Yeah, I would say point of care is the way to go because now I'll be happy to share that uh, coming from the ICMR NIIH, our institute had come out with a point of care technology for detecting severe hemophilia A and von Willebrand's disease. It was the brainchild of our former scientist, Dr. Srimati Shetty. She, along with her postdoc student, they had worked on it, and these kits are out in the market now, actually. So these are definitely going to change the diagnosis and management. Like, firstly, these can be the first line diagnostic investigations for any patient presenting with bleeding disorders. Even in places it can be done where you do not have specialized diagnostic testing facilities, the what we call as the gold standard testing. Or these kits can be used in places of emergency or casualty departments in hospitals, ob-gynae departments, hemophilia chapters, and the HTCs, the hemophilia treatment centers. And the early diagnosis will definitely ensure initiation of appropriate therapy, and then it will eventually lead to reduced morbidity, mortality, and then eventually you can go for a detailed investigation and have the actual values. But uh, uh, in the first line of diagnosis, these POCs will definitely be very useful because they have some inherent strengths, like generally these POCs do not require large sample volumes, so that is an advantage. The cost is much lower if you compare it with the traditional testing in the laboratories, because that will go in the thousands. If you go in private, then it's very high. Even if you compare with the detailed investigation charges in government setup, even the kits will be much less expensive. Generally, the reproducibility, because its kits are very well validated, so they can give good reproducibility. And most biggest advantage is that you do not require a highly trained staff to use these uh, POC kits. So that's a big advantage. You don't need very high-end equipments, and you can get the results in like quick 5 to 10 minutes time. So the POCs are definitely the way forward because we can reach out to communities. and identify. So this gives an opportunity to identify more number of patients than just relying on laboratories. Because as I said earlier, we have about 1,40,000 expected hemophilics, and across all the chapters, we have about 92, 93 chapters all across the country. Taken together, we have only about 29,000 patients registered under all the chapters. So this number definitely has to go up, and these kits will be really helpful. Talking about the molecular diagnostic, yes, now we have the next generation sequencing and all the other molecular gamut of investigations available for hemophilia, but then you definitely need more centers which are well trained. Now, how many of these centers are trained? Very, very few. Even currently, we have, as I said, only one or two centers. So we need to have more centers where people are well trained. Now, when we talk of NGS, there are certain, no, it's not as easy as you send it for NGS and you have all the answers. So the interpretation of the results have to be done very, very carefully. How to disclose the reports to the patients? It should not directly go to the patients. There has to be, these reports have to be interpreted well. So all these things are there. They may have also have some ethical considerations when we report directly the NGS reports to the patients. So these things have to be considered very seriously. But yes, we have now high-end investigations available to our disposal, and they will definitely be promising to have a better diagnosis and better molecular testing in the coming days.
Thank you so much, Dr.
Kulkarni
Bipin.
were another.
Yeah. So,
Kulkarni day, we can't hear.
I would like
Hello.
to ask the next question to Dr. Neeraj. So, what clinical protocols or red flag system would you recommend to ensure earlier suspicion and investigation of hemophilia, especially in rural hospitals? So, you're on mute.
Sorry, it was automatically on to mute. Sorry.
Hmm.
Uh, so, uh, uh, so I think I would start with history again. Even at a remote center, 2/3 of hemophiliacs can still be picked up from a very careful history. The history is going to be a little different here. We have to ask with a suspected male child with hemophilia is, does he have a brother with a hemophilia? Does he have a maternal uncle with hemophilia? Or does he have a grandfather with hemophilia? So this is a little different history than you ask whether your father or mother has hemophilia. If you ask me whether your father or mother has hemophilia, you may not find out. So you have to ask if your brother has, your maternal uncle has, or if your grandfather has. So that's the history that we should learn to take, and I'm sure we will diagnose more hemophilia just by taking a proper pedigree charting, or and then we'll suspect at least that okay, this patient, this member of the family might also be hemophilia. Please test that person also, because as clinicians sometimes we are probably guilty of looking into only our patients in front of us. We probably have to also think that okay, there's some other family member who might be affected and who are out there in the community whom we have to diagnose. So that is one important thing, I think, even in rural areas where you don't have any facility, you could have the history. Second thing, I think we are a big fans of the ICMR developed point of care testing. We have used it extensively in our outreach activities, where we have done 4 or 5 outreach activities where we have used the point of care kit developed from ICMR. I would say that it's extremely useful, and we are really experimenting how it can be used in different ways. So like one of the things is we could uh, we have used this, like we have family members who come to us. We have a patient who has already diagnosed, and you have a brother who is there in the family, and then you could say that you could test it and then say all you need is, at present you need a centrifuge, small centrifuge, and you could take it to the community outreach, and then you could do it in the center that you are examining this patient, and then you have a 5 minutes where you know it's just like a pregnancy test. It's a very simple to read, and yes, and it usually gives an yes or no answer. So we have used it to find out if the family member is affected or not. And of course, some of the things, it also helps to see if some hemophilia A, this is at present developed for hemophilia A and not for hemophilia B. So sometimes they have been diagnosed as hemophilia. They don't know if it's 8 deficiency or 9 deficiency. And so, I mean, sometimes you could use this kit to confirm whether it's an 8 deficiency. So and so it of course we have done this to confirm. We have taken samples back to the hospital and confirmed it, and most of the time it correlates. Most of the time it correlates, almost every time. So so I think that's one of the and it's very less costly. 300 rupees of one is what I think what it costs, as against 2000 or 4000 rupees for the conventional factor assays. So definitely uh, such kits will help increase the diagnosis. And I think ICMR is also trying to see whether it can be done in whole blood, but that will be a great achievement if they're able to do that, because it will make things even more easier. Second, third thing is, what tests can be available in a rural area. If you don't have a point of care test, if we have at every district hospital, at least in Kerala, what has been done is every district hospital is now equipped with a semi-automated analyzer. So the semi-automated analyzer is going to help in other things as well, pre-operative investigations also. So you don't have to buy it just to diagnose hemophilia. The state can buy it also for other reasons, right? It will help in screening for many other basic things. So if you have a semi-automated analyzer, then you could do a PT and an APTT. And an APTT, a prolonged APTT, will be really prolonged, and that will help you hit the diagnosis of hemophilia. At least you could refer that patient to a higher center.
Thank you so much, Dr. Neeraj, and thank you so much for explaining how all and what all tests are available to diagnose hemophilia. And I believe because of the advancements, technologies, and the clinical research which is happening at a very fast pace, we have all these options available, and all thanks to our healthcare industry, medical industry, and the people who are working day and night for this. So, moving on to my next question to Dr. Vijayakumar. I hope we can hear him. I think he's still not connected with some. Okay. So, Dr. Kulkarni, if you'd like to answer, can can you share a specific example from the field where community level interventions have led to faster hemophilia detection?
Uh, yes, so the Hemophilia Federation of India is doing a lot of good work to to spread awareness uh, amongst the bleeding communities, the hemophilia families, and uh, in general, to facilitate or to promote better awareness about the disease. And uh, basically what is important is not to or to curtail the spread of wrong information, because it is as important to spread the right information and to stop the spread of wrong information or misconceptions about the disease. And you know uh, once somebody gets the disease, and what are the next steps. So all these uh, spreading the awareness amongst the families once a patient is diagnosed in the family is very very important. Because, like, for example, if you take a girl whose brother is hemophilic and she turns out to be a carrier, then we have heard of cases where she's counseled that all your children will be hemophilic. Or once a lady is diagnosed to be a carrier, then uh, they have been getting advices like you can go for adoption directly. So these are the misconceptions one has to. So you there is a need for awareness, not only to identify a bleeding disorder, but also once it is identified to spread the right information to these families. And patient organizations like HFI is doing a good work in doing that. And of course, the medical fraternity, we as an ICMR institution are also partnering with them, with the World Federation. Also, we are doing projects for the outreach, and just to spread the awareness about the disease, and to increase the number of patients that we can bring under the umbrella of care.
Thank you so much, Dr. Kulkarni, for addressing all this misconception and myths, which is there, or I believe told to the patients. But I think that's why we are doing this kind of sessions to create that awareness, to bridge that awareness gap which is not there. So thank you for answering that. Moving on to my next question to Dr. Vijayakumar. Sir, can you hear us? So I would like to
Am I
know
audible?
what you're audible,
Yes,
sir.
Hello.
yep. Yes,
Yes,
sir.
sir.
Okay.
So I,
Okay.
I
Okay.
would like to know what
Yes, please.
role do what role do frontline healthcare workers and ASHAs play in early identification, and how can their training be enhanced for hemophilia awareness?
These frontline healthcare workers, ASHAs, are doing a wonderful job, especially in Kerala, and they can play a very important role in the detection of bleeding disorders. This is particularly important in the case of women experiencing excessive bleeds during periods, delivery, etc. They are our frontline healthcare workers who can educate the families during their home visits and other nutrition clinics, etc. They can also dispel the myths regarding the curses which is going on in some of the tribal villages, encourage early reporting of symptoms, and they can document the relevant family history and report to the medical officers. In case of a positive diagnosis, they can give a regular follow up also. With the introduction of e-health, the portal e-health portal, they can enter the events also, upload the events also. They can associate with the chapters of Hemophilia Federation of India, which is playing a very pivotal role to educate the public as well as the healthcare workers. And the Hemophilia Treatment Center Aluva in association with Hemophilia Societies of Angamali and Kochi have arranged several sessions at least once in a quarter. Our handholding institution Amrita has given us logistical and academic support in all our activities. The government initiative Asadhara, as Dr. Neeraj mentioned, has introduced testing facilities in all 14 districts in Kerala to the extent of factor assay. So that is a the previously there was only one center in Aluva doing it, but now we have 14 centers which are doing the coagulation studies up to factor assay. And a project impart training to selected school teachers is also being implemented by the government of Kerala under the Asadhara project. So these steps will definitely improve the understanding of the disease amongst the public as well as amongst the healthcare professionals also. Healthcare professionals also have to be educated about the disease. And this is particularly, especially important bleeding disorders, especially apart from hemophilia, von Willebrand's disease also requires special mention in this regard because this year's theme is women and girls bleed too. Their case also has to be taken care of. and the incidence of on-Miliband is 1 in 10, 1,000, whereas hemophilia is only 1 in 10,000. So these preliminary symptoms, bleeding symptoms, have to be taken care of and brought to the attention of the healthcare personnel for further follow-up.
Thank you so much, Dr. Vijayakumar, for answering that and for sharing your insights as well. My next question is to Dr. Neeraj Siddharthan. So, from a clinician's standpoint, what are the most critical element of national awareness strategy to bridge the gap between first symptoms and final diagnosis?
Yeah, so this is indeed a very interesting question. So, my perspective is that we should have four pillars on this strategy. One is education, and of course, education means, of course, education to the doctors and as well as the patients as well. So, doctors' education, I think, during our MBBS curriculum itself, uh, the the topic hemophilia and bleeding disorders needs to be more emphasized, and at the level of the MBBS training itself, it needs to be emphasized, and post degree training also is very much needed. Continuing medical educations to be talking about this. Um, of course, second is infrastructure development as far as the government is concerned, which some of the models that we are seeing, especially in the state I'm coming from, we have seen a decentralization of the um, 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 care, as well as a hub and spoke model, where you have we have traditionally in Indian healthcare system, you have a primary healthcare, secondary and tertiary healthcare centers, and if the care should be available from the primary healthcare, and they should not be able needing to travel to a secondary or a tertiary healthcare to get their main treatment. So here, in case the question that you asked about the ASHA workers bringing the health care to directly to the doorstep is going to be very important. So that infrastructure building is and integrating hemophilia into this structure of primary, secondary, and tertiary. Like you have physicians at the primary healthcare being able to think about hemophilia and diagnose, especially the pediatricians who are going to see the children first, and we need to involve the professional organizations of pediatricians, also and primary care physicians who are going to see these children first, and they have to start thinking about hemophilia, and and then if once they start thinking about hemophilia, and they should be able to do the testing, and they should be able to uh, find a center very reasonably near to get the testing done. And that's where the district level empowering of the district hospitals is going to be very important, and that's a good model, where if you can have the district hospitals in each district of the country being empowered to do the APT testing, and some of them being able to do the factor assays as well. And then is the skill development, which again, skill development can be imparted through education, but at a professional level, and once you start practicing also, it's important for the organizations like government or the private centers to impart the skills to the practicing physicians. One of the important aspects also is to include the patient organizations like Hemophilia Federation of India and their chapters involved in the care of the care of themselves, because that also is found to help in the overall uh, improvement of the care, especially in the they would also help new patients, um, being diagnosed, because those with the family history, I think, if you divide into those with the family history and those without the family history, I think those with the family history, we should be able to diagnose hemophilia in a child before he develops a symptom, because we already should know that the child is likely to have hemophilia when the child is born. So even before the child develops symptoms, we should be able to diagnose hemophilia in a child who has a family history. Okay, in those who do not have a family history, I think the rest of the measures which I mentioned about, taking the care to the doorstep and empowering the primary care physicians and getting diagnostics investigation at the district hospital level. And of course, a critical tool here also would be to popularize the point of care kits that ICMR has been developing. And it shouldn't be. We should also think about genetic diagnosis, which Dr. Bipin was mentioning. Uh, but I think that's also going to be a very important thing. And recognition of women with hemophilia, the carrier women also who are also symptomatic, we shouldn't leave out as a men's disease. So women are also affected, and then the psychosocial aspects also need to be addressed. So in general, when there is a national policy, a comprehensive care, it's just not about diagnosing alone, but after diagnosing, how are we going to take care of a patient for their entire lifetime? So it's a disease for the lifetime to be treated. And so once diagnosed, once you're ready to diagnose, you should also be ready to treat them further, and that vision should also be there.
Thank you so much, Dr. Neeraj, for explaining us that concept. And now moving to my next question, Dr. Bipin. So, given your leadership in research, how can partnership between diagnostic labs, research institutes, and public health program help amplify the early diagnosis efforts?
Yes. So, as I said earlier, uh, what is important to have early diagnosis is uh, giving access or patient having access to a laboratory which is close by. Uh, so to have more labs, so first what is important is an advanced center or a research center can share their expertise and in capacity building. Like we also do a lot of capacity building exercises, so that in the form of trainings and workshops. So a research institute can train laboratory staff, technicians, as well as the pathologists. So we have this design of one pathologist and one or two technical staff from a primary lab for these kind of workshops. So this design works well for training and capacity building exercises, which is very important uh, to bring up the lab. So once we have these kind of trainings, then continued hand holding is required. So one time training does not help, because we have to build confidence in them that yes, they can go back and do the testing. Because uh, when we are around, we are giving them training, that time they are kind of depending on us, but once they go back, then it might take time for them to build that confidence to independently do the assays. So it always gives them the doubt whether our results are correct. So we do the hand holding, and the labs should also take the initiative to come forward and show the willingness to do the diagnostic, undertake the training, and go ahead and do it. So that is one where the partnerships can be really helpful. Also, these will help the smaller labs which are trained. Uh, we can share the protocols and harmonize the protocols so that they use the same protocols that we are using, or the bigger lab is using, so that it helps them build the confidence of doing the testing correctly. The and As I said earlier, the POCs they can use, and these can be made available by joint programs. The POC devices, the community, as a service, or maybe NGOs or the state governments can procure these kits and they can give to these centers. So that can be one thing that can be done. Also, the public health programs can centralize data from the labs and the research centers to monitor the prevalence, outcomes, and other the diagnostic gaps that can be done, where these can pitch in. Also, the point is where the data generated through the collaborative studies can be useful in formation of guidelines, the national guidelines. So, compilation of data, and that can be done. The public health entities can extend the research findings into educational campaigns, uh, about early signs of bleeding disorders and how to diagnose them, and eventually that will be also be helpful in identifying the possible carriers in the family. So I think these are some of the things that can be achieved by doing partnerships with the laboratories and the institutes together, between the diagnostic lab research institutes and the public health organizations, I think.
Thank you so much, Dr. Bipin, for answering that question. And now, with this, we have come to end of our discussion. But before we end, Dr. Vijayakumar, can we have a short closing message from your side because we couldn't hear you much due to the internet connection.
Yeah, I am very sorry for that poor connectivity because
No
I
problem.
have we have now actually I have been with the hemophiliacs for the last 30 years. First time I had no idea what hemophilia was. When the first, I am a pediatrician basically, not a hematologist. When the child was brought to the casualty and was screaming with pain, I had no idea what hemophilia was. He had only a small white card saying from the CMC Vellore saying that hemophilia patient is hemophilia A severe and can be treated with cryoprecipitate factor VIII concentrates. At that time that was available. So I went back to my quarters. I was the resident medical officer. Went checked with Nelson and found the dose of cryoprecipitate and got it from IMA blood bank. That is how I started with it. And in the last decade, we have seen through the plasma derived recombinant, then extended half life, then non factor therapy, everything. So it has been a marvelous journey in the last decade, and there is still hope for the hemophiliacs to lead a normal life, at par with the normal people and engage even in sports, because these non-factor therapies have come as a miracle. So I think there is hope for the future, and the early detection, of course, will definitely reduce the disabilities. 10 years back, 70% of the people became disabled by 17 years of age. Now, with the start of non-factor therapy, we rarely see patients with disabilities. So we are very happy with what has been achieved in the last decade, and hope for better in the future.
Thank you so much, Dr. Vijay Kumar, for sharing a closing message and your expertise with us. So, thank you to all the esteemed panelists for sharing your insights, vision, and experience. And today's conversation highlighted the urgent need for collaboration efforts across healthcare, policy, and community to improve the early detection of hemophilia in India, and been very helpful to create that awareness about hemophilia and the timely detection and why this can help us a lot, right? So we are grateful for this, and thank you so much for joining in and giving your time and sharing your insights. Thank you so much.
Thank you.
Thank you. Thank you very much. Thank you.